Наш вебинар
The webinar is dedicated to all the activities pertaining to care and support interventions for people with TB and drug-resistant tuberculosis. I will start recording.
Запись это только идет сейчас на английском языке. Запустите, пожалуйста, на русском.
English recording has been already started.
Если не получается, тогда мы можем попросить...
Все, спасибо. Спасибо большое. Алекс, там уже
Thank you, Alex. Dear colleagues, I'm sorry for this technical glitch. My name is Elmira Gurbanova. I'm the coordinator of the Virtual Medical Consilium. As usual, you can listen all the speakers and view presentations in both languages. They're available in Russian and in English. You need to select the proper symbol on the panel, and all the recordings of the webinar will be available at our webpage, our platform, and at the same platform you can find all the recordings and all the materials of all the previous webinars. And I'm very glad to pass the mic to Dr. Askar Yedilbayev, Regional Advisor on TB and Drug-Resistant TB of the Joint Unit on Communicable Diseases of WHO Europe in Copenhagen. Askar, the floor is yours. Elmira, thank you very much, dear colleagues. We are very glad to welcome you at our Jubilee 25th webinar of the Virtual Medical Consilium. And today's topic, which will be covered by our distinguished experts, is really important. It is important for the implementation of your proper implementation of your work. And the typicality of this issue is really high, and therefore quite often, in addition to clinical aspects, we try to cover programmatic components and share experience of various countries of our European region. Very briefly, I would like to say that we have had 25 webinars, and given the need, we see the need you express, the interest you express, will continue our work. We will continue the operation of the Virtual Medical Consilium. And I would like also to ask you not to hesitate to send and present all your complex cases in your clinical or programmatic cases to the Virtual Medical Consilium, because we are here to help you and we will continue work. I wish all of us successful work, and I would like to express our deep gratitude to the experts who will present today, and also share our gratitudes for Elmira Gurbanova. Askar, that's really a good news that our Virtual Medical Consilium will continue its work this year. And without further ado, I would like to pass the mic to Olha Klymenko, who represents CEO TBPeopleUkraine people from Ukraine, who will share information on digital system as a model of social support for people with tuberculosis. Olga, please, the floor is yours. Thank you very much. Do you hear me? We hear you loud and clear. First and foremost, I would like to thank WHO Europe for the opportunity for the TB community to take part in such important events and to strengthen collaboration of the vulnerable communities and healthcare providers in order to improve quality of care and improve the comprehensiveness of all the support provided for people with tuberculosis. Slide number 2. My name is Olga Klymenko. I represent national organization TBPeopleUkraine, as it has been already said. And for those who are unaware of our organization, I would like to say a few words. Officially, we started our work in 2018, and everything started with a small group of activists, people who were experienced in TB, who faced certain challenges, and with the pursuit to change things, with the support from the Global Fund, we started mobilizing the voice of people with TB in Ukraine. Until 2018, there had been no systematic activities. Our organization has priorities at the front of work, but we also support all the work aimed at strengthening healthcare systems, because international funding is always a good thing when it is available. But the priority for us is that national policy takes into account the needs and the rights of all the vulnerable populations. Therefore, in solidarity with global objectives to vanquish TB, to fight TB by 2030, we do our best to consolidate all our activities with all the national priorities. Next slide, please. Here you see the areas of work for 2024, and I would like to tell you about how we came to supportive services. Initially, we worked in advocacy area only, and we are not a service organization. We didn't provide any supportive services, but at the same time, we are an organization which gathers people and has huge access across all Ukraine. And we work implementing intersectoral collaboration approaches, because with decentralization, which we see in Ukraine, we have a national level of decision making. We have also local authorities, which also have certain mandates to fund local programs, implement local programs. And now we have at district level to work with population in remote and small places of residence. Therefore, our advocacy work is aimed at building political commitment from the grassroots, from healthcare facilities, and upwards to the highest level, to the parliaments and cabinet of ministers. And we work in close collaboration with huge support from the Ministry of Health and Center for Health, our national program, because in our work it is really important to work in dialogue with all the stakeholders, not directly involved in public health. We need support of strong leaders, and for us, those are the people in the Ministry of Health. We work on working with stigma, we work on fighting discrimination, we also work on legal norms and documents, and through local authorities we try to build programs and we advocate for funding allocation and for service provision. Unfortunately, with the start of war, a huge section of our activities had to be changed, and like happened with many partners abroad, because now we have another area of work, humanitarian aid. It's a all new direction, but during war, this is the most important, the most topical area of work. As you see in the news, we have broken down logistic pathways. We have more complicated access to medical and supportive services, and we have ongoing constant rocket attacks and on healthcare facilities, and therefore our humanitarian aid targets people and healthcare facilities, from food parcels for individuals to some reconstructive works to repair some critical aspects which are critical for continuation of work of healthcare facilities. We coordinate our humanitarian aid with a national program, and we provide aid after joint decision. We have strengthened this area with the war. We will speak about in more details, but the pandemic was the starting point for digital service provision. When people were isolated, when people had to be alone, but support was still a factor needed. And therefore, we needed to find a decision on how to continue service provision when we could not face people face to face. And we needed to decide what to do at the level of towns, villages, and with the stop to be partnership support, we implemented the implementation of a mobile application, and in 2024 this digital system, which is accessible through the mobile app and through info boxes, which have been installed in TB facilities, and through info boxes, which will be installed at the level of primary healthcare, in the centers of primary healthcare, and also through hotlines. With the support of our donors, in Japan, Fuji, we also received 2 portable X-ray systems, Fuji systems, and at present, TB community, in close collaboration with medical community in 2 regions, which alternate based on the decision made together with the Center for Public Health, are used to detect cases. So today, from advocacy, we have moved on to the whole cycle from detection to the cure, and we provide the whole set of supportive services to people in close collaboration with all the projects which exist in Ukraine. Next slide, and I will tell you more about the services we provide. As I have already mentioned, the system is presented here in the slide. The person applies. We receive the information in our unified call center, which process data received from across the region, and our ecosystem is built so that after the call center, we have more than 73 non-governmental organizations, more than 50 of which implement social supervision services with the support from the Global Fund. When we receive an application, we verify it, and we get in touch with the person, and we initiate the process in our database. Our data and the verification process during the war have been increased. And now, next slide, please. And the questionnaire looks like this. We gather information on whether a person belongs to a vulnerable group, on whether the person had to pay for medical services, on the level of awareness about the fact that the treatment is free of charge, on the received supportive services, on the level of satisfaction with medical services, and with the quality of supportive services. A person presents a barrier he or she faced, and we assess how the barrier impacts the adherence to treatment. So the person has to tell us whether he or she will continue treatment if the barrier is not eliminated. We also gather data on the type of TB, on the duration of treatment, on the duration of inpatient treatment, on the start of the supportive service provision, and the whole set of data helps us to present recommendations based on the patient's pathway, so that from the detection to the cure. Regardless of the duration of treatment, a person felt comfortable during that process, and that the person knows where to turn to for help. We also get in touch with the healthcare provider and the non-governmental organization working in the region. If a service can be provided, first, the patients always provide the agreement. Confidentiality and safety is of utmost priority, and person should know how the information will be used. As we don't have such organizations, we have a central office, and we communicate through electronic systems with all the national programs. When a person agrees, a doctor confirms that some support is needed, and then a staff member from the non-governmental organization gives us information whether that can be covered through the social support project. If it is possible, then we direct the person and then call once again to confirm that this support has been provided. If the support cannot be provided through the existing projects, then with the confirmation of the national program that the intervention is needed, for example, a person needs costly diagnostics. We are not physicians. We need to receive a confirmation from healthcare providers that that's exactly needed for that particular person, so that no matter who pays for that, not to duplicate work, so that all the interventions are really important for the treatment, and so that it does not affect the quality of treatment. So we make the decision is made collegially together with healthcare providers on diagnostics, on drugs, and on other aspects of treatment. In 2023, we received more than 2,000 applications, and you can see that 20% of them were in the area of discrimination. Discrimination is not only related to healthcare providers, but we try to investigate all the cases of discrimination at the level of healthcare providers. And multisectoral accountability framework, that's a very important tool for us. And we can also implement interventions at the level of other ministers, but I will tell you about in more details a bit later. We get applications on stigma, sometimes information pertained to drugs, sometimes information on the treatment of concomitant diseases, when, for example, treatment is not covered by different programs. Mental health issues, we see an increase in number of requests for psychological support, financial support as well, because we understand that the distance from healthcare facilities, humanitarian aid, all the negative consequences of war. We also work on tracing adverse events, but all in a dialogue with healthcare providers, and that information is used to inform a national program so that they are needs-oriented and help to really cover the aspects faced by people during treatment. I would like to present a few numbers, but you should understand that behind the numbers we see lives. Kharkiv is the third biggest city after Kiev. Kharkiv and Dnipro under constant bombardment, and people try to leave, try to fled, and try to seek evacuation, and all the, for example, a man left Kharkiv and lost all the documents, and according to the legislation, a person without legal documents cannot seek free of charge healthcare. So at that moment, we couldn't help because of organizational issues. We provided follow-up. We paid for all the fees to make the legal documents. We also helped with the communication with the official structures. All the documents were restored, and documents I passed to get treatment and social support as an internally displaced individual, and also to receive some support as a victim of war. So we helped the person to restore all their legal status and continue proper life after treatment. And the follow-up is continued. We periodically get in touch with people to see whether they really continue treatment. Another example, an application from a woman with TB of skin, and we understand that it's a bit different. It's a less frequent form of TB as a drug susceptible or drug resistant TB. It's not an issue of physiological health, but also psycho-emotional health, because all the signs were in the face, and therefore psychological pressure was really huge. We helped that woman with diagnostics. It was a very complex thing, and we also helped with a supportive treatment and with psychological support, so that she could focus on treatment, and so that she had hope that that was only a temporal issue and everything will get eventually better. We also receive application from people, for example, application from a woman with 3 kids. Unfortunately, her husband died from TB because they could not provide help. And as there are difficulties with timely medical help seeking, we understand that people are responsible for their treatment and for their help, in addition to the fact that healthcare is available. People should feel responsible for themselves and responsible for late presentation as well. But unfortunately, the husband had died, but the woman and 3 children reacted properly. They all were diagnosed. All 4 people right now receive support, because our social support projects in the country are not sufficient enough to be on treatment for the mother with 3 kids without any paid job. With PathUSaid, we open special rooms for children and for the parents who are on treatment, so that they bring children to spend the day, and there are psychologists. It's a safe space for children. They have also access to distant learning, online learning, and with the existing evidence base, we can build all the activities. It's impossible to come to, for example, to the Ministry of Education and tell them that they are engaged or involved in the fight against TB. It's very difficult to convey the message, and the same applies to any other structures not directly involved in healthcare provision, because unfortunately for quite a long time TB was considered the sole responsibility of the Ministry of Health. Therefore, today, together with the Ministry of Education, we prepare special courses for teachers in schools, for tutors, for lecturers and higher education facilities. We also work on education activities in order to build awareness from the very early age, so that there is no thing as stigma. And we want TB to become a disease that is curable and that doesn't frighten people. We want this diagnosis not to cause all these negative feelings. We also work in the legislative framework in order to establish a safe environment in the area of employment for people who need to interrupt their work because of TB. And if people get treatment on the outpatient basis and face side effects, so that the employers understand that there should be certain um, that there should be better conditions, a better environment for people on treatment. We also work with the departments of the Ministry of Health, or in charge of fund and mechanism. We have developed a special course for healthcare providers on tolerance and non-discriminatory policy at the level of a healthcare facility is a must. Through a secret visit, we assess the impact of all the activities aimed at stigma, because all healthcare facilities need to implement a set of activities to fight stigma among the staff. We also work with the social policy, Ministry of Social Policy, on the activities aimed at supporting vulnerable families, children, on providing support to people with addictions, so that we don't only treat TB, but help people to get back to normal, healthy life. We also work in such areas as access to support if you don't have documents. And we also work with journalists, with mass media. We develop special guides which help various structures to present TB in the area of their responsibility. That's not that doesn't cover all the aspects of our work. It's impossible to present all the activities we perform together with the Ministry of Health, with the Center for Public Health, because we want to present non-medical structures as well.
So now we see that tuberculosis is a priority, but we have to say that the general population is prone to tuberculosis, and not always we can ensure face-to-face social support with the engagement of the social workers. Smartphones and internet is available in the time of digital technologies, and we would like to use the new tools and instruments that we try to improve all the time, and this way our patients have the ways to communicate with the treating physicians at the convenient time. With the use of artificial intelligence coded for the majority of the requests in the context of tuberculosis in order to reduce the need for face-to-face communication will be very helpful in provision of support to people who will be able to get the necessary information on the current condition and on the necessary steps. And this information will be received from the smartphone and from the virtual supporter. The projects of social support are limited by the availability of the donor funds and other aspects of financing, but we would like to develop the public health policy in which people will understand that through caring about their health, they will get some benefits. We can do that through the stimulation programs, motivational programs, and games. And people, through the use of these tools and through the network of partners, will generate certain benefits. and will provide the necessary assistance without alcohol, drugs. They may receive books or some tools and piece of equipment, depending on the daily outcomes. For example, if the person received timely treatment, went for a walk, got some fresh air, this kind of behavior will be supported by the psychologists. Now, this program has been submitted for revision to Johns Hopkins University because our main goal is to make sure that we do not hurt people through our programs. And since the time of diagnosis and since the time of indicated treatment, patients will be able to start on treatment totally confidentially, and no one but treatment physicians will know about that treatment. And no one will know that that person has tuberculosis. So I am approaching the end of my presentation. This is my final slide, and as I have mentioned earlier, some time ago, vulnerable communities could not even imagine to be invited to the WHO webinars, and they could not imagine that we will be able to work side by side, providing support to people. Now, the trend in collaboration has changed a lot, and it is changing very quickly, and we see that we can save a lot of people. And I would like to say in conclusion that the war in Ukraine, more than any other challenge, showed the value of collaboration and support, or whether it's support provided by a physician to the patient, or it's support coming from an NGO. We all demonstrate our responsibility, and we approach people with trust, because people do deserve to have their treatment centered around their needs, centered around respect to people. And we know that there is only one step from doubt to result. All you need to do is to start acting. And I'm very grateful to all partners for great support provided to Ukraine. And we see that support from the medical community to the government and partners. And of course, there is only one path from goal to result, and only together, only in collaboration with each other, without any hostility, and without focusing on negative aspects, but focusing on positive aspects, we will be able to overcome tuberculosis. There are some definite steps that can bring us to the victory over tuberculosis. And should you have any questions, I will be glad to answer them. You can see our contact information, and we'll be glad to share our experience, to share our knowledge, and hopefully we will help experts in other nosologies, other fields of medicine, to offer good care to patients. Thank you very much, Olga, for sharing great experience of your community in providing care to people with support of broader community and partners. I would like to remind you that our questions and answers session will follow after all our presentations. And without any further ado, I would like to give the floor to the next speaker, Oxana Rucsineanu, from the National Association of TB Patients in Moldova. Oksana will share the experience of Moldova in the field of psychosocial and social support in the Republic of Moldova. Thank you very much, Almira. I hope you can hear me very well. I would like to welcome all participants on behalf of Moldova. the results of our activities are not the results of our agency, but these are the results of the country teamwork. Quite often, we say that the National TB Control Program is not just the program that develops health policies, but these are all actors who, at different levels, implement the best achievements available in the country in order to make sure that our TB patients, TB communities, and families affected by tuberculosis would be able to achieve very good results in treatment of tuberculosis, and this is our main goal. I will make my presentation in Russian, and I will start.
Just a few words about our organization. I'm presenting in the same time the National TB Patient Organization that is a non-governmental and non-profit organization registered in 2010 in the Republic of Moldova that supports people affected by TB and their families. We strongly advocate as an organization for an inclusive and equitable public health system. We are protecting for the rights of people with TB, and we are promoting strongly people-centered care in the country. Since 2011, we have promoted the interest and advocated for patients in front of various stakeholders, TB stakeholders, and not only TB stakeholders in the country, including heads of local health centers, clinicians, health care workers, local public authorities, ministry officials, parliamentary members, and of course, WHO officials and partner donors. As areas of engagement, we are focusing on TB rights, advocacy and policy change. We still have some service provision related to active case finding and psychosocial support as an organization. We are doing community engagement and research and development, and we are strongly focusing on collaborative partnership. If we're speaking about the psychosocial support, I will have just a few slides focusing on theory. This is the definition of the psychological and social support, some practice, which we are actually implementing in Moldova, and some conclusions, and those aspects which still need to be refigured and fortified at the country level. I used the definition which is actually developed and is included in the psychosocial support report developed by the WHO European region. It is available on the WHO page since 2020, and it gives these several definitions. We are speaking about when we are speaking about psychosocial support, we are speaking not only about psychological support. We are speaking about emotional and spiritual support to address the social, emotional, and economic determinants of psychological health, including common issues such as fear of death, depression, anxiety, behavioral problems, difficulty dealing with side effects of treatment, helplessness, hypochondria, problems of responsibilities, and others. When we are referring to social support, we are speaking about support in solving socially significant problems of a patient and his family, including job loss and financial problems, child care arrangements for social security, nutrition, lack of housing, money, violation of rights, and so on. At the same time, we in TB cannot speak that we have a clear definition and we are using just psychological or just social support, because often it is a mixture of services, and in this case we would better use the notion of mixed services, which is aimed to address simultaneously social and psychological issues, which implies any form of support that is aimed at helping people to overcome their rising or ongoing psychological and emotional problems, rebuild social structure with the overall aim to complete successfully the treatment. If we are speaking about the input of the civil society, we would better say that civil society organization, non-government organization, usually provide psychosocial support because they don't have this clear distinction. that seems to be an issue, but from the other point, namely this flexibility of using support without distinction allows the help to be adapted and to respond to the needs of a patient and his family. Next slide. I'll move it. If we are speaking about provision of psychosocial support in Moldova, we, as every country and every which is here presented at the webinar, we have support provided within inpatient and outpatient. At the same time, the support in order to achieve a quality standard of care, we need to be focused on people-centered care, and we need to focus and to strengthen multidisciplinary approach. If we are speaking about people-centered care, the focus of a people-centered care is to see a person as a whole, with many different needs and goals coming from the social determinants, not just the immediate requirement of medical treatment. That's why when we are dealing with a TB-affected family or TB-affected people, we need to understand that beyond the focus and the goal of a patient to get the medical treatment, there are many others which need to be addressed simultaneously and in a proper manner. We need for this a strong primary healthcare system, clinical approaches to give our psychological and social support. We need to adapt to care delivery according to the needs and to coordinate the health services and psychosocial services at the community level. Of course, we should, where it is possible, and we all know already the role of civil society organization, to engage organization and communities in providing this people-centered care, trying to respond to all the problems and needs of our patients. And of course, we cannot neglect the role of a family member, of relatives, friends and neighbors, which sometimes have a very strong influence over the patients and can help a lot in helping patients to adhere to a treatment. Multidisciplinary approach is referred to a broad interdisciplinary and multidisciplinary approach, which leads to improved quality of health and social services. The key to success is actually coordination between primary care, healthcare specialists, TB specialists, specialized institutions, as well as social services, and including by civil society. I'm not saying about providers, because providers can be on behalf of both public services and civil society. Ultimately, this allows a broader view of patients' problems and perspectives and help design a variety of problem-solving options. This approach as well promotes and empowers the people-centered care that ensures the rights of people with TB are respected, along with improving the country's TB response outcomes. The types of psychosocial support, I will not go by them, but you can see it on the slide. Almost every country in our region are using similar approaches in providing psychosocial support, which refers in several directions. We're speaking about health literacy, awareness raising and advocacy, stigma reduction, social support, financial support, provision for vulnerable people with special health condition, emotional, psychological, and legal support. In the country, we have, as I said before, psychosocial support, which is provided as a standard of care, and it is provided in the inpatient settings, which are free in our countries, free hospitals. And then at the level of hospitals, we have psychosocial provision as part of the overall care. It is generally organized and structured and mostly focused on side effects and status acceptance in the initiation phase of treatment, because we are not actually advocating for reduction of hospitalization. And in this case, this is mostly about increasing the acceptance and in the phase of starting the treatment. In the outpatient settings, we are the approaches of providing psychosocial support are actually based on multidisciplinary approaches. It is done, as I said, to address socioeconomic problems, stigma, challenges between at the social level, gender differences, inequalities. They are both provided by public services and, of course, by civil society organizations. There are different teams of specialists engaged in providing psychosocial support. We have teams, we have individuals, we have NGOs, we have public community centers, and we have governmental agencies and civil servants. If we're speaking about strategies and policies in the country, the psychosocial support is provided within the provision of the law on health and the law on social protection and the law on TB. So during the period of TB treatment, benefits are provided in accordance with general provision of the legislation on disability and other social security benefits. People who have temporarily lost their ability to work due to TB are retained at work for the period established by the current legislation. We have two different comprehensive guidelines that regulate the provision of TB standard of care, and we are speaking about TB in adults and TB in children. Both TB guidelines include provision for psychosocial support. We have separate boxes. You can see boxes for psychosocial provided for adults, and we have separate regulations to provide psychosocial support for children. We have a very strong nutritional support system. It refers to the transport cost reimbursement and support, which is given to all patients irrespective of TB profile in outpatient settings. It has started in 2011 from the resources of the TB of the Global Fund, but we managed to implement this practice at the country level already from the domestic funding, and we have a joint order of Ministry of Health and National Health Insurance Company that regulates the provision of these services. We as well having some difficulties in implementing the mechanism. At the end of the last year, we managed to change this modality of provision, and starting with January, all TB patients will be provided with this support on social cards. So everyone will just receive a social card and go in any shop or market and take the products they are actually more comfortable they actually need, not that we dictate them what to take and in what conditions. That was a hard job. We did advocacy together with the National TB program for 3 years, and we are very happy to have it already implemented. Just some figures. In 2 years, 2021, 2022, absolutely all the patients received for this purpose more than 1 million and approximately, I'm saying 1,200,000 euro. This is designated from the domestic funding, and this is for absolutely every patient in outpatient treatment. As well, we have a community center support. This is another initiative which started with the resources of the Global Fund. We had which included the psychologist, social worker, and duty supported, included in the team of the TB department. This was initially funded from the Global Fund resources, but it was institutionalized and included in the overall TB care provided, and now available in 1/3 of the TB multidisciplinary teams at the district REN levels. And this is a public service which is available. Still, it is not in every, unfortunately, not remained in all the TB teams, but that's an issue of advocacy, and we will continue to do that to ensure that this happens and this is sustainable. We as well have BCT treatment option available since 2019, which was extended countrywide in 2020 available. That's a good option to increase adherence and give people possibilities to choose what's better for them to ensure that they are adherent to treatment. As well as BCT is a digital tool. It was complemented last year with a module on community-led monitoring, and it is it isn't basically the same what is done by TBPeopleUkraine, but the main focus is to record all the issues people in treatment are facing, to ensure to respond to them timely and not to allow people drop the treatment. This is done as a part of overall support. At the country level, as a public services, we have 40 community mental health centers. This is a public services, which consists of psychiatrists, psychologists, social workers, psychiatric nurses, and they are all part of a complete team trained to identify and treat mental health problems according to the provisions of the national clinical protocols. What remains is actually to use this resource and to refer people in treatment when they face psychological and emotional breakdowns to the existing treatment services. Since 2020, the Ministry of Health has introduced a formal approach to sustain the cooperation between civil society, state institutions of local authorities, and we actually shared this experience with Askar when he was visiting Moldova last year. This is about having a standard base in providing active case finding services and treatment initiation and support provided by civil society, which is actually based on clear working algorithms described on a 20-page document, which is approved and which is regulates the activity of civil society, mostly as it regulates an activity of a public service. That's a good step for us. Additionally to the Global Fund resources allocated for the civil society, we have allocations for the activities done by the civil society in the overall volume. You can see on the slide, it's not a big volume, but it's a big step for the country. Since 2002, it's already a kind of routine practice. We are doing it already for the fifth year, with volumes being increased and with civil society becoming more and more integrated in a way in accessing the public domestic funding. As well, what we managed to do as well for the civil society is to develop and improve the cost for TB screening activity provided by this civil society, which is regulated by an order. We have as well as a public service already legal assistance granted by the state, which is available at all districts. We have their lawyers, we have their paralegals, and we have a civil society organization actually working in HIV and TB, who will train TB paralegals already and include them as a staff in this legal assistance granted by the state in the country. As some conclusions, I would say that provision of psychosocial support to people affected by TB is an integral part of the National Disease Response Strategy and Plan, being included in national guidelines for TB management. Psychosocial services is implemented in partnership with multiple stakeholders. We have NGO, we have local authorities. Thus, the most effective models of support services are improved and sustained. We're speaking how something which was initially started and financed from the Global Fund actually has the roots and continues already to exist within the resources, domestic resources. Annually developed Ministry of Health orders set up the basis for sustainable community support systems, which link and coordinate existing services with each other and to health services. Multidisciplinary approaches for psychosocial service allows the development of different models of care, along with defining the role for every member of a team. Capacity building for provision of psychosocial support is for different providers we're speaking. For public services, we're speaking for services provided by civil society, in the training curricula for the next 3 years, supported by the Global Fund resources. Funding additionally to what is and what we have from the domestic funding. Funding for psychosocial support, including restoration of identity documents, because that's a priority for the country. Provision of hygienic packages for 30% of TB patients, and we are speaking about most vulnerable, is secured in the country Global Fund program for the next 3 years. However, people social support, and we cannot speak about the challenges because otherwise we will not have the chance to increase and improve our services. The support is provided, the support which is provided by civil society, both in inpatient and outpatient settings, are financed from external sources. Therefore, we think it's necessary to identify potential domestic funding sources for psychosocial support and develop and approve a cost for this type of service, similarly as we managed to do it for TB active screening. We already have a bullet point to fulfill. This will allow to ensure sustainability in the long term so that the services could be planned for and delivered consistently from domestic funding. More efforts on domestic resources should be mobilized to ensure community center support as part of the overall TB care is provided and funded all over the country, not only in part of it, and more coordination. That's I think that's still a gap, and linkages should be in place, including monitoring and accountability to ensure we efficiently use what we have at the country level. Thank you for your attention, and just to mention that we are a strong team on behalf of civil society comprised of 10 different organizations which covers all the country, and of course to acknowledge the efforts and the work we are doing together with the National TB Response Program, with primary health care, local public authorities, Ministry of Health, National Health Insurance Company, TB Caucus, PASS Center, WCHIMP, donors and development partners. Thank you so much. I'm waiting for your questions.
Большое спасибо, Оксана, за прекрасную презентацию.
Thank you very much, Oksana, for an excellent presentation. By all means, psychosocial support is an important component of support to TB patients, and we could see that from your presentation and from the statistical data shared by Olga. And I hope very much that the national and international partners will pay attention to sustainability of this support. Thank you very much once again, dear colleagues. And now I would like to say that you can ask your questions in chat, or you can ask them later on during our questions and answer session.
Dr. Bakyt Myrzaliev from Kyrgyzstan. He represents KNCV and Kyrgyz National Medical Academy. He will share the experience of providing support and care to people with TB in 20 minutes. The floor is yours. Thank you very much. First and foremost, I would like to thank on behalf of KNCV and National State Medical Academy for the opportunity to participate in this Jubilee webinar, and I will continue. You can start sharing my slides. We are waiting for the slides to be presented. I would like to say that in Kyrgyzstan, this work has been conducted together with KNCV Kyrgyzstan. It's a local organization. Next slide, please. Here you see the history of our success, our patients. And before I start telling you about the support and care, we need to understand the situation with TB in Kyrgyzstan. According to WHO, the estimated number of patients is more than 8,500, but we detect only 4,500. In 2022, only 4,500 were detected, and it means that not all the patients are detected, and COVID-19 pandemic has had significant impact. Many patients had no access to detection services, to care and treatment. And starting 2020, we have seen an increase in the number of progressive cases, and the estimated number of patients has increased as well. And here in the graph, you see the mortality increase over the recent years. Before we pass to support and care provided to TB patients, we need to explain it to the organizations which provide this type of services and to the communities. They need to understand what is TB and how a person can contract it. It is called by Mycobacterium tuberculosis. It's an aerial disease, and key symptoms, it's the chest pain, cough, fatigue, weight loss, and fever. So these are the key pieces of information we need to provide to the organizations and communities. And as at the global level, TB is a huge problem of the public health, affecting millions of lives annually. And it is a significant challenge for the public health in the country. Understanding the basics of TB is crucial to ensure effective prevention, early detection, and comprehensive care and support. Here you see TB is not only the issue of the TB services. It is not the issue of public health services. It's a more complex issue with far-reaching negative impacts for the health of individual and community, because it is stigma related. People face social stigma, discrimination. This disease also has negative impact on mental health of patients, on social relationships, results in isolation and the reduction of income. In our country, we don't have concrete data, but we are going to work in this area. And we also understand that the consequences, it's the disability, loss of productivity, which all places a burden on state budget, because TB is related to additional payments and benefits, disability-related benefits, loss of productivity payments, and these altogether can place a huge burden on healthcare system. And knowing these far-reaching consequences underlines the need to face and tackle all the barriers faced by people with TB and by the communities in order to ensure cure. And like our head of the department said, we need to treat patients, not the disease. And we teach our patients, treat a patient. And we are taught in medical facilities that we need to provide holistic care compared to what we had several years ago, when self-resolution was up to 10%. Today, we see that novel drugs, novel diagnostics can treat up to 90% of patients, if they even more than 90% of patients, even with wider form of TB, concomitant cases such as HIV, TB, we can cure many people. But all our care should also, in our work, we should strive to improve emotional, spiritual well-being, and psychosocial support, as shown by our studies. Is a must. More than 90% of people face depression during the diagnosis, when they are left alone with the disease. That's a crucial moment in life when a person faces huge stress, which further exacerbates physical state and reduces the resilience and ability to persevere. Therefore, we need to ensure friendly environment. There are many cases when even parents of old children step back. They try to distance because of their fear, because TB is related and surrounded by huge stigma. And at this moment, we need to provide psychosocial support. Therefore, when we explain it to people who provide psychosocial support, that it is important. And now it is a bit easier because we have digital solutions and digital means such as a mobile phone and messengers like WhatsApp, when people can share all their negative feelings and their concerns. But in the past, when a person was excreting bacilli, smear positive XDR or MDR patients, with whom it's difficult to be in face-to-face contact. And we should understand that people who provide social support or psychosocial support or psychological support are also exposed to a certain risk. Therefore, we understand that we should take into account multifaceted aspects of tuberculosis as disease and treatment, and this helps to improve the overall quality of life of TB patients. And so what are the examples of best practices in this area? What are the successful models? Kyrgyzstan hasn't started from scratch. We used MSF successful models, ICRC work in prisons, also nursing support from the Great Britain and the United States of America, individual support, including to the patients with TB. Innovative approaches have been also developed in Kyrgyzstan based on evaluation of people diagnosed with TB, provision of information and educational, psychological support on the basis of partnership, and the patient-centered approach. That's really important to take into account individual needs and preferences in order to make support and care more personalized. And there have been important lessons learned from the global experience. We've been able to accumulate experience and translate it into practice. Next slide will show that during the implementation of Challenge TB project, my colleagues, together with Morabet, who was the lead of the group, developed this case study. The first thing we do, when get in touch with patients, evaluate their education level and their needs. And it helps understand that this person knows nothing, only myths, only disbeliefs that TB is a hereditary disease, for example, and based on personal traits, personal level of knowledge, a personalized plan of support and education is developed, including trainings and consultations and counseling, including family members and care providers who will work further with the patients, volunteers, and other people who support treatment on the outpatient basis. Involvement of local authorities and social insurance services is important because it is not only monetary payments. This type of support includes food parcels or, for example, coal, if needed, to heat homes in winter. We have many religious organizations which also allocate certain support, because patients cannot seek support actively. It's important there is something who would guide them, who would be the advocate, who would ask other organizations to provide certain support, who will turn to local authorities or maybe philanthropic organizations. And because there are certain institutions which can provide support. And when we start raising awareness and educating, we meaningfully engaged patients, and quite many of them then stick with us. People who have had TB, who have successfully been cured, they become volunteers. And within this project, Challenge TB project, which was implemented with the USAID support, we see that in this cohort of patients, we've managed to reduce default rates to 3% only. And next slide shows that. So what models were used? The key model, visiting houses. If we, for example, lost a patient, for a week a patient, for example, hadn't turned up for treatment, then we would visit and even we visited remote areas. For example, we visit shepherds in the mountains far away, so we're using even sledges to reach people. Damira and Chulpan and other people, dedicated people, and they all continued to work with us in TB control. Some of them became coordinators, some MDR, TB treatment coordinators, and this is our contribution to TB control. With the next slide, I would like to say that we used digital solutions. We live in digital era, and therefore we developed special application for managers to follow up patients, to get rid of paper-based documentation. Everything was centralized in order to simplify the work. We digitalized it. We provided tablets or other devices, digital devices to the managers. We had an IT specialist who helped to perform adaptation, localization, so to say, of the application. And we are really grateful for all the technical support provided. Eventually, we ended up with VOT, WhatsApp. We used video records and direct video calls. It was the cheapest and the most simplest way. For example, it's a mother of 5. Her children contracted TB. Unfortunately, her husband at that moment didn't believe in TB cure. You know, there are many disbeliefs. Some people use kumis to treat TB, some certain insects, and some people go to shamans and healers. Therefore, it is really important to debunk myths and to convey the message that it's a curable disease, then more than 90% curable, that all the drugs are available free of charge. The mother, Zarina, mother of 5, you see, some people also, like her husband, said that that was the God's deed, and with 72 written refusals, we couldn't do anything. We wanted even to initiate the legal procedure to apply to court, but to no avail. Some people agree, some refuse, but I can say that about 80% of people agree. But this lady, Zarina, she had to continue working to provide for the children. And the children receive treatment on the outpatient basis. She would need to take her children to a healthcare facilities. It was 2018, 2019, close to the conclusion of the project. And VOT system helped to improve their lives. She just made a video call, and that was it. And the children were cured. It's another situation.
So this is another success story. We see that people were taking care of their sick grandmother, and in the framework of the Challenge TB project, they did not have to visit the doctor on a daily basis, but they received support through the video support group. This is our patient guide that was developed in the framework of our project. And on this slide, you can see the work in some remote areas. You can see the level of satisfaction of the patient. He is very happy to see his nurse, and he shows successful drug administration. And this is actually how it happens in real life. During the COVID-19 pandemic, we had to adapt. In the past, we used to provide the drugs for several weeks and even months. And the Ministry of Health adopted the developments of our Challenge TB project and supported it. On this slide, you can see our patient who was sent to palliative care, but we were able to find bedaquiline and start introduction of the shorter treatment regimens. We were able to save life of this patient who received video-supported treatment. More than 884 patients on the new treatment regimens received some individual support throughout their treatment. They received regular consultations, visits, phone calls from the project case managers. And case managers also checked patients for side effects, provided TB educations, and helped patients solve any obstacles to their treatment, whether psychological, financial, social, or administrative challenges. In the framework of this project, we also implemented the survey among the patients in order to find out the variety of obstacles that they encountered. The majority of them said that side effects became the most obstacle for them. Another second group of obstacles is psychological challenges, followed by stigma, isolation in the society, and loneliness. Manifested by depression. And on this slide, you can see the answers of the members of our population. And we see that some people refuse to eat or drink together with friends who have tuberculosis. The majority of them said that they were afraid of such contacts. About 90% of people said that they were afraid of patients with tuberculosis. Despite the fact that we know that after 2 weeks of treatment, patients stop being infectious. Apparently, we need to deliver this information more persistently and clearly to the public. We need to promote people-centered care and support. And for the World TB Day, we had this kind of activity that was coupled with the informative sessions aimed at raising the awareness among the public about tuberculosis and its successful treatment. Of course, it is very important that such agencies as MSF, KNCV, AFU provide the necessary support. It is very important that some of them work with inmates, provide psychological support. KNCV implemented a number of models of care. A few also promoted some innovative models of care, and they continue working with us in support with other donors and partners such as USAID and Global Fund. TB people provide support to ex-inmates upon their release. ICRC provided support to the local legal counselors and actively engaged people with the experience in the field of TB support and care. The foundation of the mandatory health insurance also provided an enormous support. We were able to save some funds due to effective treatment, and some funds released because of that were transferred to the primary health care and were used for support of the primary healthcare workers who promoted successful treatment. So we were able to provide incentives to the healthcare workers for successful treatment of drug-susceptible and drug-resistant tuberculosis. So they received about $120 per successful treatment of drug-acceptable tuberculosis and $250 for successful treatment of drug-resistant tuberculosis. And of course, in their catchment areas, they have about 6 patients who are being treated successfully. This is a good incentive for the healthcare workers. We also try to provide support to the social workers in various programs. The Red Crescent Society, with the support of the Global Fund, also provided support. Red Crescent Society also participated in the loan project, and they participated in the distribution of the pill boxes. This project was not absolutely successful, but at least we've learned about these models of care, and we also sent our experts to Moldova, and they learned more about it here, TB and other programs that are available now. And with support of the donors, we could be able and willing to implement them in the country. Because of the experience of the donor agencies, Kyrgyzstan receives precious information on effective treatment and is able to engage very dedicated people to TB control. On this slide, you can see some challenges in TB control in our country. So what are the current challenges? They include the existing challenges in TB support, which include limited resources and stigma. We know that the flows of money from the budget are quite limited, and we know that our population is not sufficiently informed. We need to raise public awareness in order to ensure timely self-referral to healthcare. However, most of cases are being passively detected, and we lose cases of tuberculosis. So we need to improve motivation. We do receive some new equipment. For example, we received a new tool for tomography, which is especially important for management of childhood TB. We also need to consider the potential of our private providers, and we need to enhance collaboration between the stakeholders. Of course, collaboration with communities is very critical, especially in the context of limited resources, and it helps overcome stigma and solve infrastructure issues. Of course, communities are very flexible, and they have better access to patients, and Kyrgyzstan is looking for the global developments and best practices on support and care of people with tuberculosis in order to get some insights, adopt and implement them in practice. We would like to use the best developments in TB care in Kyrgyzstan in order to develop a sustainable TB support and care in our country. On this slide, you can see the list of recommendations for enhancing TB support in Kyrgyzstan. We see that it is very important to implement integrated awareness campaigns. We need to develop comprehensive public campaigns to reduce stigma and build a friendly environment, increased early detection, and promote understanding of tuberculosis within the communities. Of course, we need to invest in training programs. We need to establish community-driven initiatives that empower local residents to actively participate in TB prevention care and support activities. As for the public-private partnership, we do need to foster collaborations between the government, private sector, and nonprofit organizations in order to maximize the resources and reach a broader audience. We need to ensure a more effective and inclusive TB support system in Kyrgyzstan, which will ultimately contribute to better health outcomes and will help reduce TB prevalence in our country. I believe that was my last slide. Thank you very much for your attention. Here we can see our contact information and the link. If you click on it, you will find the video with our patients who was on treatment in our program. You can find out more about the activities of our NGO. Thank you very much, Bakyt, for a very inspiring presentation and a very good example of the benefits of patient-centered approach to TB care. Thank you very much. We have only 4 minutes left before we come to an end of our webinar. I don't see any questions in the chat, but dear colleagues, should you have any questions to our speakers, you can raise your hand and ask your question, or you can share your questions in chat. I don't see any questions so far, but in any case, on behalf of the Secretariat of the Virtual Medical Consilium and on behalf of our team of presenters and the audience, I would like to thank the presenters. I would like to thank you for your hard work. Thank you for looking for the new solutions, your tireless work aimed at provision of good TB services that cannot always be covered by the TB control program. And these services become the task of NGOs, civil society organizations,